This is a 66 years old male with a large pancreatic head mass as demonstrated by CT scan, and he is now referred for endoscopic ultrasound examination and staging for this mass and assessing the resectability. If it is unresectable or borderline resectable, then EUS FNA will be done for possible chemotherapy for palliation for unresectable masses, or neoadjuvant chemotherapy for downstaging in borderline resectable masses. Now the endoscopic ultrasound in the second part of the duodenum, and this is a large pancreatic head mass, and these are the nearby vessel. So we will apply pulsed wave Doppler, and this vessel is showing venous pulsations. So this is the superior mesenteric vein, and this is showing arterial pulsations. So it is the superior mesenteric artery. So the mass is abutting less than 180 degrees of the superior mesenteric vein and abutting less than 180 degrees of the superior mesenteric artery, and this is the aorta and IVC. So this mass is borderline resectable because it is abutting the superior mesenteric artery. This case is 45 years old female complaining of dull aching, persistent abdominal pains in the epigastric and left hypochondrial region, not responding to PPI and spasmolytics. Sonography was done and revealed the presence of left hypochondrial cyst, mostly in the pancreatic body and tail, and CT confirmed these findings. They describe the presence of a complex cyst in the pancreatic body encroaching on the tail region with enhancing cyst wall. So the patient was referred for further investigation by endoscopic ultrasound. Now we are starting examination of the pancreatic body and tail from the stomach in the fundus just below the cardia, and here we notice this is a large cyst, and very important to notice here that there is a mural nodule. This may be a mural nodule, maybe a mucus plug, or maybe necrotic area, but here we notice a very important sign that there is a big vessel inside this nodule. So it is a very grave sign to find a viable vessel inside the mural nodule, and this vessel is arterial. So it is a big arterial vessel inside the mural nodule, which is a very grave sign for being a cystic pancreatic neoplasm, not an inflammatory pseudocyst. Yes, this is the splenic artery and splenic vein. This is the splenic vessels, and this is a big arteriole inside the mural nodule, and this is a large cyst. Now we will do FNA and EUS guided fine needle aspiration of the cyst to do cytopathological and chemical analysis of the fluid. The rules of cyst aspiration is first, try to do only one puncture. The second is try to aspirate as much as you can. Try to empty the cyst completely to decrease the risk of seeding. When you aspirate the cyst completely, then the pressure inside the cyst will be very low or minimal, so there is no pressure to push the fluid out of the cyst, so minimizing the risk of seeding, and of course prophylactic antibiotics before cyst aspiration. Some recommends avoid cyst puncture in the body and tail because the needle track will not remove during operation if the cyst proved malignant. and they allow aspiration from cysts in the head because this tract will be removed during open operation. But others aspirate the cyst, recommending aspiration of the cyst. So here there is a debate, but in this case we decided to do cyst aspiration to be sure of being cystic pancreatic neoplasms, because the patient will undergo major surgery. Now we are using 19G needle because the fluid is turbid, so we use the widest FNA needle, and we are now aspirating the fluid, and we will try to aspirate as much as we can. After cyst aspiration, we should do the string sign or the stretch sign. Yes, here it is a positive stretch sign. Yes, positive stretch signs. More than 4 or 5 millimeter, it is positive. So it denotes mucus secretion or mucinous secretion, which is predictive of mucinous cystic neoplasm, and its accuracy is about 90%. The cyst fluid was sent for cytopathological and chemical analysis. Cytopathology revealed positive mucin stains by Alcian blue and the presence of cells containing mucin, and shows moderate dysplasia. So the cytopathology is suggestive of mucinous cystic neoplasm. Chemical analysis revealed markedly raised carcinoembryonic antigen, which is very specific for mucinous cystic neoplasm. It was about 4,000 nanogram per milliliter, while amylase was normal. It was about 25 unit per liter. So excluding the diagnosis, or nearly excluding the diagnosis of inflammatory pseudocyst, in which the cyst amylase usually very high. The CA 19-9 is 35,000 units per milliliter, but unfortunately this is not specific for mucinous cystic neoplasm. It is also raised in inflammatory pseudocysts. So the most important two markers in the cyst fluid, the first one is carcinoembryonic antigen, levels above 800 nanogram per milliliter is highly predictive of mucinous cystic neoplasm, and here in this case it was 4,000. And the second marker is amylase level, which is usually raised in inflammatory pseudocyst, but also raised in intraductal papillary mucinous neoplasm. It's not the case here because the pancreatic duct was not dilated, but more important is amylase level when it is very low or normal, so it points away the diagnosis of inflammatory pseudocyst. So this case is a classic mucinous cystic neoplasm, classic by EUS features of mural nodule with a viable arterial vessels inside, classic by giving string sign after aspirating the fluid, classic by the very high carcinoembryonic antigen and the very low amylase level. So the final diagnosis was cystic pancreatic neoplasm of the pancreatic body and tail, and of course the patient was sent for surgery for partial pancreatectomy. A 45 years old female complaining of dull aching epigastric pains, not responding to PPI and spasmolytics. Abdominal ultrasonography was done and revealed pancreatic body cyst. So she was referred for further delineation by endoscopic ultrasound. Endoscopic ultrasound examination at the subcardial fundal region revealed this multilocular or multicystic structure in the pancreatic body. It is not invading any of the vascular structures. measuring about 3 by 4 centimeter, with a large number of cysts. The differential diagnosis includes many types of pancreatic cysts, like side branches IPMN or serous cystadenoma, but it is not typical of a certain type of pancreatic cysts. So we decided to do EUS guided fine needle aspiration for more clarification of this pancreatic body multilocular cystic lesion. EUS FNE was done using a 22G needle, and the precautions of cyst aspiration from the gastric body is try to do only one puncture and to aspirate as much fluid as you can from the cyst to minimize the instance of peritoneal seeding. And of course, prophylactic antibiotics should be given before cyst aspiration to prevent secondary infection of the cyst. This is the aspirate of the EUS FNA. It is milky white fluid, so it was something unusual to obtain this milky white fluid, raising the possibility of lymphangioma. It is a rare cystic lesion of the pancreas, and this material was sent for assessment of level of triglycerides in addition to the tumor markers. The tumor markers were not raised, were normal, while the triglyceride level was 1600 milligram per deciliter. So the diagnosis of cystic lymphangioma of the pancreatic body was made, and this is a very benign lesion just for follow-up. So this is a very interesting case showing that EUS FNA is very helpful in diagnosis of this benign lesion. So major operation was avoided, and the patient was justified for follow-up either by CT sonography or endoscopic ultrasound.